is everyone? Early still? Good morning. My name is Adimika Arthur, and I run a nonprofit called Health Tech for Medicaid. And today we're here for a program on innovating for the future and how pediatric and youth care transformation in Medicaid. So we're going to go ahead and get started. I always like to give frame for why we do this sort of work. Health Tech for Medicaid is a nonprofit organization. We've been around almost 6 years in about 2 weeks. There's election day, and then a few days later, we launched at the National Association of State and Territory Medicaid Directors after I spent a very long piece of my career advocating for Medicaid. So I was a hospital leader for about 15 years. Prior to that, wrote the 1115 waiver in the state of California, which expanded Medicaid, so deeply have been involved in Medicaid for quite some time. By training, I'm an epidemiologist, and so data is really important to me. And I think as a hospital leader, when I found that we had all this stuff that was coming out of Silicon Valley and all these great inventions, and not very many people were interested in focusing on the Medicaid space, I was a little confused. Because to me, that's the closest that we have to a single-payer system. And really the the most vulnerable populations that we have in our country. I'm just going to give a little frame as to why we're here today. So pediatric care in Medicaid is deeply personal. Medicaid is 59 years old. It's on its way to being 60 next year, which is a very pivotal moment. And a lot was happening in 1965, but Medicaid originally started as a women and children's program. How many of you guys knew that? Couple, yeah. And so it really was to preserve the lives of our young folks. And we're going to get a chance to hear from young folks today on our stage around how do you co-design solutions. We're also going to open up to other pediatric innovators in the field, so you actually see that oftentimes we are up on stage and we're talking about all these great movements and things that are happening, and then we really don't see anything tangible solution-wise of people that are actually doing the work. And so that's our goal today. But when you look, 44% of children in this country are on Medicaid. It's a very big group of our kids. So deeply thinking about not just solutions, hopefully, that are for adults only, but when we think about families in our communities and many of our caregivers, right? We caregive for our elderly, but we also caregive for our children. All right, and here we go today, I think. Let's see. Maybe not. Okay, I think I just talked about why pediatrics was so critical in Medicaid. I think that's good. All right. We're going to kick it off to today's panel because I want to be respectful of folks' time. And I'm going to actually go to the left and to the right and have people introduce themselves. Dr. Ivor Horn is downstairs on stage, but will be coming up shortly. So just if you see someone flying in, that will be her. But I'm going to start with you, Faith. Can you introduce yourself? Tell us a little bit about who you are, what you do, and also why you think innovation in pediatrics is really important.
All right, good morning. I'm Faith Polkey. I am a pediatrician and also preventive medicine and public health doctor. I am currently the CEO of my health center in the Low Country of South Carolina and have been there 22 years. And so have had the opportunity to see a lot of changes within pediatric care. So when I first got to my health center, we were still seeing patients as an outpatient, but we were also going to the hospital. So I was a hospitalist and also an outpatient doctor. A 25-week baby, mom delivered a 25-week baby. We had to go and see that baby and transfer them to a higher level of care. So, that's pretty rare these days to still be able to do that kind of thing because we've compartmentalized a lot, but we've had a lot of course, innovations that have happened. It's important. Kids need us to be thinking about that next thing, and they need us to be those champions, but we also have to listen to them. My 13-year-old daughter has definite opinions about how things should go. And so I think it's just important for us to center children and ensure that they are not just at the center, but also in the conversation too.
Great. Travis?
Good morning, everybody. I'm Travis Gayles. I'm the Chief Health Officer for Hazel, and like Dr. Polkey, I am a pediatrician. My focus area is in adolescent and young adult medicine when I practice full-time. So I definitely understand that teenagers needing to have solutions that speak fluent teenager to them. And including them as a part of the conversation. And really excited to have some young people here with us to be able to share their thoughts. I'm excited about innovation because I think innovation is one of the most effective tools to leverage equity and increase access in a meaningful way to solutions that are high quality, low barrier entry points, and address the real needs of the folks that they're hoping to help. Adimika and I have talked before about this. One of the things that I'm really excited and passionate about the work that she is doing is because historically, anytime we see innovation in an area, it is typically skewed towards those who have commercial and private insurance, those who have access already. And we know that those who have Medicaid or however other way you define it, typically there's a multi-tiered system. It's like, hey, yeah, you have insurance now, good luck. So how do we leverage innovation to help families navigate through that system? How do we leverage innovation to speak more fluently in a teenager-based way so that it resonates with young people? So really excited to learn more from the folks on the panel and engage with you all in the audience around how we can leverage that more to create some comprehensive solutions.
All right, Jennifer.
Hi, everyone. I'm Jen Magaziner. I'm the Vice President of Digital Health at Boston Children's Hospital. And core to our mission at Children's is innovation in peds, obviously. For digital health in particular, it's so important because for all the digital health solutions that are out there, peds is often the last stop on their development roadmap. And so we really work hard to partner with a lot of early stage innovators in this space to help them design for pediatrics earlier on so that we are not an afterthought. So very excited to be here today.
Wonderful. And our lovely youth representatives or young adult representatives, please introduce yourselves. Kimberly or Kim, we'll start with you.
Hi, good morning. My name is Kimberly Moreno. I'm a youth representative, so yeah.
Just tell us a little bit about yourself. Are you, what are you doing in the world?
Oh my gosh, it's working in school, and it's really tough. I never realized it was going to be this tough, but I'm making it through some way, somehow.
All right, Fatima.
Hi guys, good morning. My name is Fatima Magayon. I am a former Rancho student, high school student. I am currently a newborn photographer for the Valley System Healthcare. I am trying to run my own small business. And God, it's so hard. It's so hard out here. It's testing patience. But I'm excited to be here and learn a little bit about you guys.
Yeah, well, thank you. I think it's always really important that we think, and I don't know if there was a few people in our session on Sunday, we had a session on venture capital and the safety net, and one of the things we pushed out was how do we co-design? And we're going to talk a little bit about co-design because there's one thing for the last mile to be pediatrics, right? When folks think about a product or a service or delivery system, they often are thinking commercially insured first, people with discretionary income, then they're also going down the list, right? And so Medicare comes next, and then maybe Medicare Advantage comes before Medicare, and it's this truncated hierarchy. But rarely do we have folks who co-design with the folks that they're actually trying to serve and actually have ways in which they're bidirectionally working through that. And so a couple of years ago, Josh gave me a little bit of a challenge at Hazel that we talk about innovation, but we often don't show that we're working to co-design our products better. And so this is a birthing of that conversation. And so I want to go to you first, Travis, around a little bit around what has co-design meant for Hazel and why you guys have decided to go that route in the way that you guys do your product and service.
Yeah, I think at the core, co-design is based upon the notion of meeting your client and customer where they are and understanding that full picture. And in pediatrics, we know that part of that is clinical, and then the other significant part of that are non-clinical things, the social determinants that are impacting the child's ability to be present and whole. And so the approach that we've taken, and so Adimika mentioned Josh Golomb is our CEO, who will be a part of the expert roundtables. So encourage you to speak with him. Part of that approach is taking a whole child approach around, being able to meet the clinical needs, but then also setting up a system that helps identify and address those other factors that, again, influence a child and a family. And so co-design that approach has also allowed us to, from the very beginning, make sure that we aren't perpetuating that multi-tiered system that you talked about. And so thinking through solutions that not only work for those who have, commercial assistance, but thinking through those obstacles that might impact a family who is on Medicaid in terms of addressing and getting to their resources. So one of them, the big issue that I think that we have helped families navigate is around care navigation. And so when we're talking about innovation, it's important to leverage technology, certainly to help facilitate a better clinical experience and outcome. But then I think it's also incumbent upon us to think about innovation in the perspective of how are we connecting kids and families to those services that they need. Because again, we celebrate the fact that yes, overwhelming majority of children have insurance these days, which is great, love it. But many kids are still locked out of the resources that they are eligible for. Either they don't know they're eligible for it, they don't know how to access it, or there are physical barriers that prevent the families from being able to get there. And so, again, going back to the co-design piece, we've been able to create a virtual platform that helps remove as many of those obstacles as possible. And one of the things that stands out to me is that utilization rates have been high across the board, regardless of insurance status, regardless of geography, regardless of racial and ethnic background. Because I think when we talk about creating those solutions for this population, it's easy for those of us on the design part to say, well, they're hard to reach, or we tried and no one came through, as opposed to thinking through how do we remove as many barriers as possible to make it more seamless and easy for folks to participate.
Wonderful. Dr. Horn, I know you just arrived from another speaking engagement. I'd love for you to introduce yourself. We literally just started. Just introduce yourself a bit about your role, not only as an investor, but also as a board member representing the hope and faith and longevity of children on the delivery side.
Thank you. Thank you for allowing me to be here. My name is Ivor Horn. I'm a pediatrician and health services researcher by training, and I have had many roles leading the Center for Health Equity and Diversity at a children's hospital, the Children's Hospital in Seattle, spending a couple of decades as a researcher and a clinician in a primary care clinic in the community at the Children's Hospital in Washington, D.C., serving the communities in Southeast D.C., and then taking on roles as chief medical officer in a company that served self-insured employers, which meant we were caring for employees and their families, everyone from your Comcast cable guy to the NBC Universal executives, and also spending time in my role as Chief Health Equity Officer at Google. One of the things that I'm even more proud of is the role that I play on the board of Boston Children's Hospital. And having been in the position, sitting in the role of reporting to the board, and now being in the position on the board to support the teams who are doing this work, to think about how do we serve all the children. I'm going to let others give the number and the data of children on Medicaid in this country, in making sure that as we're building and we're thinking about innovation and thinking in all of the wonderful things that you're hearing here at the conference, that we're thinking about how do we look at the information there and what are we building for the next generation to help them be healthier, to help them live more productive lives, and how do we integrate that into our health systems and into our processes and our clinics and our workflows in a way that is not just for those who come into our four walls, but those who are outside of our four walls, and understanding what's missing in the data, in the understanding of whether those models are actually built for the pediatric populations that are being served in children's hospitals.
I love that. As we keep on this theme of co-design, I want to come to you, Faith, partially because by just showing up every day, being a leader of a health center in South Carolina, you have a board that is made up of some of the individuals that you serve. Actually, by nature of running a federally qualified health center, your board is majority community. And so I'd love to hear a little bit about any early innovation conversations, how easy or difficult that is, and ways in which you want to tell the room and the folks online what we need to do to start knitting together the steps of community understanding innovation so we can best start doing that co-design that Travis just talked about and Dr. Horn just kind of inspired.
So I guess I'll go back a little bit. So I am at a community health center, federally qualified community health center, which means that, we are a private, not-for-profit practice, pediatric practice. Well, not just peds, but we have everything: adult medicine, OB, peds, dental, pharmacy. And so like other health centers around the country, we are governed by a board. And what is awesome about it is that the board itself, we have some board members who have children who we see. They're mostly older. They're mostly older. But we do come to them and say, we're trying to do this next thing. So let me just go back to when we first went into school-based health centers. And this was very early on, late 90s. And, our CMO decided that she wanted to go into schools. And it was very new then. And our board was just open to it because they saw that as an access point for our patients. Accelerate now we are in our 3-county area. All the schools in one particular county, we take our mobile unit to all the schools in another. In our largest county, Beaufort County, which a lot of you know for Hilton Head, if you've ever been there, right? But we don't serve Hilton Head folks. We serve the people who serve Hilton Head folks, right? We have a lot of rural areas in Beaufort County and still a lot of poverty in those areas. And all of our schools are Title I schools. So we have locations in 10 of those schools. The county would like us to be in 34. Wow. But the way to get there, though, is through innovation. We were some of the first ones to have telehealth at every school. And thanks to a partnership with our South Carolina Telehealth Alliance, they gifted us all of these telehealth equipment, including peripherals. So I can have a provider at one of our schools in the Way part of this county having someone present a kid at another school. And we've just seen how, and now there's new equipment that's like even smaller. I'm super excited. There's some people here that have that equipment, but it just allows us to serve more people. We're 85% of the children we serve have Medicaid. So it brings technology to them in ways that some of the private pediatric practices don't have. But it all is because our boards put faith in us to provide a lot of the care, for our patients, our communities.
Wonderful. I'm going to go to you, Jen, just briefly. We've talked about a clinic. You're on the other side of the world, right? Children's hospitals. Having ran a children's hospital myself, I know how deeply important they are for the secondary and tertiary, quaternary care even, for our communities. Can you tell us your approach to innovation? What does that actually mean? And we'll later on have some vendors that are actually doing work in Medicaid, in pediatrics, because oftentimes people are like, well, show me, right? Show me the money. I'm going to show you at innovators who are deeply passionate and committed to the Medicaid ecosystem. But can you tell us a little bit about how you guys approach, as a children's hospital, and I know there's a Children's Hospital Alliance, how you guys approaching innovation? What solutions are you not seeing? And what areas are you most interested in learning a little bit more about?
Yeah, so we approach innovation. We try to have a really balanced portfolio for everything we do within our innovation group to both help patient families, and then also the caregivers who are caring for the patient families. I think everyone in this room knows there is a shortage of pediatric specialty expertise across the country, lowest match for pediatric residents in the last decade. So we spend a lot of time with clinicians to try to better understand what are they seeing, what are they not seeing, what do they need. There's the work that every hospital is doing to try to reduce administrative burdens so clinicians can practice top of their license. I think for pediatricians, that's particularly important. They work incredibly hard and they're paid on average less, than a lot of the adult clinicians. For our patient families, core to our mission is just making sure we can extend our clinical expertise across the globe and to any patient and family, no matter where they're born, no matter who is paying for their care. And so I'm really proud of the fact, for example, that 20% of our outpatient care is delivered virtually today. That creates a level of accessibility that we didn't have before. I'm also proud of the fact that we have more digital channels to illuminate what we're doing well and where we are missing. Where we're missing people. I think we have more data than ever before in every single health system. And so, I was talking with a friend before this session, so I think the collective challenge is how to use that good data for advocacy and how to pave the path to policy, on the federal and local level with that data as well. And then how to work beyond digital with other areas of the hospital when we identify needs, if patients aren't able to show up for an appointment, or if we're seeing a difference in engagement because of a language barrier, for example, to kind of co-design what comes next.
Great, thank you. All right, I'm gonna go down here to Fatima. As we talked a little bit about governance, a touch, right, with Dr. Horn being a part of governance of a children's hospital. Faith talked a little bit, or alluded to a little bit of, the governance of her health system. Much of it is actually individuals from the community. And now I want to talk a little bit, Fatima, around your advocacy around governance in a digital health system. I want to know a little bit about your experience as being a youth ambassador for Hazel Health, but also what it's like to advocate, because I understand you went to their executive team and presented to them and gave feedback, right, around their product and your experience. Can you tell us a little bit about that, and what does that sort of advocacy mean to you?
It honestly means a lot to be able to go stand up to big, important people. It was 2 years ago, I was 18 years old. I felt really, really young, very tiny in the room, but I felt very heard. There's a lot of things that as teens and young adults we go through that not many of the adults understand now just because of how time changes. How do I put it? It's very hard to speak up in a world where it's in a go, go, go. There's no time to slow down. It keeps growing, it keeps innovating, it keeps going, and then there's our youth where they're like, so what do we do next? Who do we ask for help? But it's considered wrong to ask for help nowadays. It's very hard to speak up to adults. Honestly, it takes a lot, even for me, to speak up. And I honestly have an adult job now, and I'm trying to go back to school, but it's very hard in an economy where you have to prioritize yourself, your mental health. You have to make sure bills are paid. You have to make sure you have food on the table for you and your family. And it's not easy to go take a step back from all the bills and be like, hey, I'm suffering from this. Or hey, we need to work more on how to get to youth in ways they can understand. There's a lot of technology nowadays, but it's not just about the technology, it's about the socializing with youth to be able to understand them. Telehealth, you guys were just talking about telehealth. It's amazing, you guys can get to all the youth and adults too, throughout the world. But if there's no actual physical contact, most youth won't pay attention.
Wow, that was really powerful. And Kim, I want to ask you really two questions, but you can answer them together. I want to know, where is technology a part of the solution to youth mental health issues, and where does it fall short?
Well, adding on to what Fatima was saying, you lose that physical contact, that one-on-one. You lose that. That's where it falls short. But where it's beneficial is that youth, I just literally just graduated 2024, and I had therapy sessions, and I couldn't go to the actual office because I was at school. And so I requested a virtual meet. And that was really helpful, but I had to step out of class, take my 1 hour, 30 minutes, virtual therapy. And it was helpful, it really was, but just somewhere my ADHD was, I was gone. It's not like I'm not prioritizing myself and my health. No, I just wish I was right next to you and just telling you everything about what's going on in this world. But it's beneficial, it really is, when you go to work. I go to work now. It's not fun.
We don't think it's fun either, honey. Don't worry.
It's not fun. Sometimes I just go home, I'm like, Mom,
Long day.
it's been a long day, please. But now with work, with the school as well, currently a freshman at Nevada State University, and they're very helpful, but that's besides the point. I don't find that time anymore to have a therapy session, at a physical place. So a virtual one would be very helpful. It's extremely helpful. People with families, they don't have time to leave kids, to leave their house. They can go sit in their living room and have that virtual therapy, virtual conversations. And I think that's where it's really beneficial, but the downside of it is you lose that one-on-one, you lose that connection. And as a youth, and me over here using TikTok, Instagram, you lose time, you lose conversational skills. You can't communicate with people anymore. And I feel like that's where technology has its barrier, it has its downside. You lose that ability to communicate, to express to yourself how you want to express to yourself to others by losing that one-on-one. And virtually, you can pretend to be someone else. Behind a phone, you are, I don't know, Camila, or someone else. You are not who you want to be. You can present to yourself, hey, I'm this super cool person that loves art and this and that. And in reality, no, I don't like that. So you get to hide yourself from others when you're doing things virtually, when you're doing things technology-wise. So I feel like that's just a mini barrier to it. Yeah.
All right, thank you deeply. I think on the side of challenges or barriers, I want to keep that going down the way. Travis, as someone who's helping to innovate a product or a service, what are some of the challenges that you guys come up with as a startup in this space?
We don't have enough time for that, but to what the young people have mentioned, Fatima and Kim have mentioned, is trying to stay present and ahead of the curve in terms of innovations. I feel like there's so much happening and so many new tools that are coming out that you're playing catch up, if you will, in terms of trying to think through what are the strategies and tools that will resonate most with the population that you're hoping to serve. I think that's one issue. I think and then within that, being able to get that right and be able to scale it up to large scale interventions. I think the second thing is being able to, to Jen's point, it's not just the innovation of the clinical tool, it's the innovation of the rest of the system to go with it. So you can come up with great clinical strategies, but will that be reimbursed? Will that be supported? Will, if we've got this clinical tool, but we know again that it's hard and difficult for the family to navigate to figure out how to get there, will all of that time that you put into helping the family navigate and connect them to services, that's a cost, that's a real cost, but is that something that's going to be reimbursable and supported so that you can be able to sustain it when you scale that up on a large scale? And I think the third piece is always thinking through, when you start the process, will this work for everybody? Because one of the things that frustrates me in conversations, and again, going back to, is when people say, well, this group is difficult to reach or hard to reach, or they won't utilize it. How do we know that if we're not engaging folks early on in the process of design, so that when we do come up with the magical clinical solution, it's something that, again, that is easily accessible to everybody across the board and doesn't, again, perpetuate the inequalities that you talked about in your introduction?
Yeah, thank you. Faith, as a pediatrician, as a CEO of a health center, as someone really leading the Innovation Council for the National Association of Community Health Centers, can you tell me any of the barriers that you think, from your vantage point, you're seeing as it relates to innovation in pediatrics?
Yeah. I mean, honestly, the biggest barrier is cost for, I'd say, us as a health center, right? So, on the one hand, right, there may be, say, reimbursement, say, for something like telehealth, and I appreciate what you were saying, because the one thing I miss the most, right, is that one-to-one interaction with patients and being in the room with patients. So I appreciate all of that. But I'd say cost, definitely reimbursement, and having I guess, regulators and know that these products are, rather it's a product or is it essential, or is it an idea? So it may be a technology thing, but it may also be my community health workers, because the things that have moved the needle for us in the last few years has been adding team members who aren't just the physician in the room, that aren't the nurses in the room, that are the people who are actually out there making those touches with patients, making those touches with families. And so understanding that part of innovation isn't just a tool, it's important, but it's also how we deliver care, and delivering that care in a way that is cost effective, because health centers do that every day. You know, we have small budgets and we make it work. We make it work every day, but it's because—
Where I learned to be scrappy, I'll tell
Listen.
you. Thought I knew how to do my budget before, but when I ran a health center, I learned budgeting in a whole other way.
Yes, absolutely. So I think those are kind of the top of mind things. So.
All right, Dr. Horn, one of the things that you are known deeply for is thinking about future state innovations. One of the hot buzz topic ideas right now, she's like shaking her head. She's like, please don't ask me this question, because everyone asked me this question. And I was in the hallway with her the other day, and everyone was like, can we talk? It's possible. So I'm going to ask you about AI. I'm going to ask you, as someone who has been in the forefront of leading innovation that we're all talking about. We're all talking about large language models. We're all talking about, what does AI mean? Youth are talking about AI and using AI tools like ChatGPT, and in some cases it's useful, in some places it's allowed. Can you tell us a little bit about some of the barriers or some of the opportunities as you're thinking about artificial intelligence as it relates to pediatric innovation?
So I'll really, usually when I talk about this, I kind of, and you've heard me say this before, I bucket it into people, process, and prioritization. And when I say prioritization, I also mean accountability. And when we talk about people, it's really important, some of the things that you all were saying around how you use technology, because when we think about who's in the room and who's a part of the process of what we're building, that really matters. And we've often found saying bringing people into the room is challenging. But the technologies that we're building are creating opportunities. Everyone is using ChatGPT. So everyone has a sense of these technologies in a way that we didn't before. And now we can leverage that to bring everyone into the room around the conversation of how we build the technologies to make sure that we're including the communities that often are not at the table as part of this process. So when I think about that, I think about people. When I think about in terms of process, how are we creating processes when we're building AI foundational models, when we're bringing those models into our health systems? How are we bringing the historically marginalized populations and the community and the youth into that process in a way that is sustainable and effective and efficient? Because it requires a lot of work on both sides, but it is doable. And one of the things that we talked about in the session the other day was around this importance, especially when you have community health centers. They have the trust of the community, they have the understanding of the community, and to some degree want to make sure that they're protecting the community. So making sure that we're privacy and security is of utmost importance, and I think understanding that is really key and really important as part of that when we talk about people and process and what's in our data and what's not in the data. I'm a researcher and I was trained garbage in, garbage out. We really have to pay attention to the data, and when data is incorporated into our processes, that data that's used to build those models is representative of our population, and how are we transforming those models to meet the needs of our populations. And then prioritization and accountability. To do this, my role as a board member is to ask those questions, is to then say, how do we make sure that that happens? When I look at the data, I'm asking the question of, what about that population? What about that community? What do those trends look like? I'm a founding member of an organization called the Black Directors Health Equity Alliance, and basically it is, and we've created a playbook really to train board members of health systems and health-related organizations to begin to ask those questions of their organizations, and how we as board directors can both hold a leadership team accountable, but also provide support for the teams who are doing the work to help them make that possible.
That's great. I guess you figured I'm going to you next, Jen. You sit in the operator role. You sit in the seat of all these vendors coming to you, and you trying to rationalize, what do we need here? What can I leverage? What's going to give us the last mile on the dollars, the limited dollars that we have? Can you tell us any of the barriers you're seeing in pediatric innovation? Are there solutions for the problems you need? Is there too many vendors? Are they too many point-based vendors? What are some of the challenges you're seeing from your seat?
Yeah. So to start, I want to build off of what Ivor was saying. If you ask any health system where they're trying to prioritize in AI or any emerging technology, it's a great illuminator for where our broader systems are broken. So, when I think about the problems we're trying to solve, one of the biggest ones is, and if you look at every health system, they're trying to leverage AI to help with prior auth, for example. And so I think one of the greatest promise areas is, how can we make sure that for a child with Medicaid, that we can make the path to eligibility confirmed and the path to payment faster? Should we have to use AI for that? No. There's a whole other series of panels on that broader debate. But so that's one focus area. We have a lot of inbounds. John and I were joking, our health in basket, it's a lot. I think we try to really anchor our priorities in the needs of the children we're serving. And so if you have a platform that's going to help us provide true connected care in a more interdisciplinary manner, fantastic. If you have a point solution to add to our already busy ecosystem, we're probably going to be less interested. But we're really focused now on platforms that can help to transform the system, to your point on process. So much of it is processes that we need to fix, the spaces between the clinical care, the navigation side. So those are some of the areas we're focused. And then, we've been doing a lot of work on clinical decision support. That's where we started in our AI journey a long time ago. And I think there's great potential for research and discovery to help clinicians someday have have greater context in how they're interacting with their patients and better understand their context outside of the walls of the hospital or outside of the Zoom room as well.
Wonderful. Okay, we're going to go to opportunities, and then we're going to see some of the incredible opportune innovations. So I'm going to have you go. We're going to start with you, Fatima, and we're going to go down. What are you looking forward to? What are your hopes and dreams for opportunities and innovation in pediatrics, if you have any?
Ooh, that's a big question. For it to be more known that there's resources out there. There's a lot of moms, especially. I see moms that are about to give birth working in L&D and postpartum, that the first thing they worry about is, how am I going to pay for my kid now? How am I going to pay for the kids that go to NICU? There's a lot of moms in NICUs that have babies in their NICU, and they're like, I don't know how I'm going to get resources for this. Mm-hmm. And the hospital sometimes doesn't even have those resources to say, oh, you guys can do this or that. So it takes time away from the parents and their kids to, oh, let me think how I'm going to make the money for this, or how I'm going to take out the money for this. Or I'll take out a loan and figure out how to pay it later. That's where I feel like innovation, and one of my biggest hopes for moms is to find peace, to know that their kids are going to be okay, and they're going to be okay without having to worry about how much they have to pay to get there.
Whew, hard to follow that one. All right, Kim.
And I have to agree with Fatima with that one, because not only how to figure out how to pay, but also kind of take away all the lies that are put out to you. A lot of times, people are told, you can't apply to welfare, you can't apply to this. Well, let's give it a try. Or you have to pay it back. And that's one of the biggest lies. You have to pay it back. And a lot of people won't get it, or won't reach out for help, won't say anything, because I can't pay it, I can't get it. So I think that's just one of the things that I feel like innovation can help and promote, and kind of just dismiss that lie that it is.
Spelling myths. Yeah. Great. Thank you. Jenna?
I think especially listening to both of you, I could listen to both of you all day. I think one of my greatest hopes is that we don't continue to sometimes innovate in silos across the healthcare ecosystem, and that we use all of this greater potential for connection to partner differently, to work together to proactively identify markers of health, markers of social need, and then work collectively towards them. I think that's the best case scenario. The worst case scenario is that we all keep continuing to think that we can do it best on our own.
Wow, it's hard to follow up on that, because I felt that deeply. I think we are sitting here talking a lot about AI and latest technology and what amazing things we can do with systems. And people need to know how to help pay their bills. People need to know how to help get food on their table. If we can use these resources, and we suffer from an epidemic of mis and disinformation. And we need to utilize our tools and our resources to help people address some of these social drivers of health. Because if you're worried about, can I feed my child? Can I buy diapers for my child? you don't care what kind of technology they have. You don't have time to get to the portal because you've got a job, and yes, having the telehealth, but I can't actually take my 30-minute break and talk to you and not eat, and not be healthy myself. And I'm living in a fight or flight constant space. If we can figure out how we can leverage some of these tools and resources to help people's lives be better so that they can care for their kids in the ways that they want to. Because I'm not going to say better care, because parents always want to do what's best for their kids. That's why I became a pediatrician in the first place. And people are innovating and learning. How do we stop having people work in our system flow and start thinking about how our systems can work in their life flow? And how can we use technology to facilitate that?
Great. Really powerful stuff up here. Thank you. Thank you. For me, it's about access. At a health center, it's ensuring that every child who is in our area, our service area, has access to health care, right? That's one piece, right? But it's all the things you talked about, because they can't even really start thinking about that until a lot of those other needs are met. And so as health centers, we are, it's not enough to just have the school-based health center or have these things available. We are having to find ways to improve the lives for our patients so they can have access, so they can come to an appointment, so they can get their immunization. And so where tools and innovation helps us do that better, easier, more efficiently, more effectively, that's my hope and dream, right?
Great. Travis, last but not least.
Everything that's already been said. I think as the science runs in innovation, we've got to make sure, as Dr. Horn mentioned, that the systems are also moving at comparable speeds to be able to meet those needs. And I think the other piece, too, is making sure that as we innovate, we get really good high-quality data that's representative of everybody to be able to inform a lot of the policies that you all mentioned, whether it's paid leave, maternal health, access. I think that's going to be really, really important as we move forward.
Amazing. All right, we're going to do a little transition. You guys know I like to do dance moves, so we're going to exit that way on this stage.
Good morning, everybody. Looking forward to hearing from a number of innovators. This has been a really great panel. I think it's framed up everything very nicely. My name is Kaakpema Yelpaala. I go by KP, the faculty director for our innovation program at the Yale School of Public Health, and also a digital health entrepreneur. And I'm the father of a 14 and 12-year-old, so this hits home. So we'd love to hear from Josh a little bit about what you guys are doing at Hazel Health.
Thank you so much. And actually, first, if we could give a huge round of applause to Kim and Fatima. Literally, in the space of a few days, they live locally and agreed to come. And we prepped yesterday, and you guys were phenomenal. So just thank you. And part of their role has been giving feedback to us on what we do at Hazel. So it's just so appreciate you guys. So the very quick version. So as you've heard, we work through schools, offering both virtual medical services and also mental health services. And the big thing that we're trying to understand first is, can we improve access first for all of our kids? And then number two, outcomes. We've been hyper-focused on looking at first things like symptom reduction for things like PHQ or GAD. But for us, the real win is, can we prove health and well-being outcomes? And so we're starting to see the correlation between, if you bring health services to all students, can you see improvements in absenteeism, attendance, and all the other things we care about that are positive life outcomes, as opposed to the reduction of the things that our young people may be struggling with. So we're in about 5,000 schools across the country and work with both the districts and the health plans.
Great. And maybe just that, since you were so quick with that, maybe you could share some of your current priorities, or where are you guys focusing today?
Yeah, so our biggest focus right now is we're doing more and more work with sort of states and health plans and the schools themselves to come together to say, how can you create a model that could be to to what our ambassador shared, no cost for all families to raise the bar for everyone to get basic access to services. So we offer both mental health and physical health today. We are finding that there's a lot of students, I think Imagine's up after us on the physical health side, that aren't getting their well child visits. The data showing that it's always been a struggle, but particularly for our Medicaid populations, the percent of students getting well child visits that they should be getting is going down. And so how do we find the right partnerships? What can we do ourselves? How do we partner with local providers to help tackle that?
Great, thank you so much. I think we've got Eden Klein from Imagine Pediatrics.
Hi, everyone. So Eden Klein from Imagine Pediatrics. I serve as their Chief Technology Officer, and I have my amazing team here with me. We are a pediatric provider group that partners with, serves children with special healthcare needs. And we partner with health plans on Medicaid to help serve these children with very acute needs and serve them in an integrated medical, behavioral, social model so that we can really help bridge the gaps that are in their care. And we partner very closely with the rest of the health ecosystem. We don't replace the PCP, we don't replace the specialists, but rather we believe in collaborating. So in terms of co-development, we're working closely with our partners, with our medical team, with our behavioral team, and with our families and patients to really understand how can we build platforms, technology, solutions that work for them, just like our panelists said today. We don't think that we know the solution, even though we have experts. We want to co-develop these solutions for them. And so we're seeing pretty good results already. We are also focused on increasing access, so it's a virtual first model. But we also can go into the patient homes, and we have a very, very good network engagement team that works with the providers to help understand, okay, if you don't have a therapist, then maybe we can be there to help and work with your PCP and your specialist on that. And so we're seeing increase of access, of course, because we have the virtual option. We're seeing a 9% reduction already in total cost of care. And we're seeing a 31% reduction in avoidable AD visits and hospitalizations, because these families, they just need to stay home, right? Because sometimes for them, the solution is I either go to the hospital with my child or I go to work and I get paid. And so how do we bridge that gap? We really want to only have them go to the doctor or the hospital when they really need to, and then we are there for them again 24/7. So we're their anchor. We're there when it's night and their child has a fever, and if they call a typical headline and their child has acute needs, it's typically go to the ED. But we have the team in place that is there to say, let us help you. We know that sometimes the families are stressed, and so we can help guide them. With our care team, with our therapists, with our medical team, with our pediatricians, with the social needs, and with our technology that is built really in a tailored fashion for this family, for these families and these patients. And we are just thrilled. I'm a mother of 3, and so I know that it's so hard to navigate the healthcare system, even for healthy children. And so for these families, when there's a language barrier, when there's the barrier of they don't necessarily understand their care plan, we're just there for them to bridge it. It feels great.
Great, thank you so much. Just one brief question. So maybe you can share something about your model that you find really works for these type of populations. I know there's a lot of people working on these types of issues. Yeah.
Yes, so we really truly believe in the power of data, and there's so much data. But the way that we do it is that we take all of the data around these patients, is lab data, pharmacy data, the claims data, real-time data around admission, transfers. We know when they go to the hospital. We know when they need the help in the transition. And we also have predictive models that we built to help understand who are the patients that are likely to go to the hospital soon, in the short term, in the long term, how can we help prevent that? so that, again, we can help change these outcomes, working with the families and the healthcare system to keep these families and these patients safe. And so our models can give us with pretty high accuracy who is in low, medium, high risk to be utilizing soon, and we can be proactive about that. And we really truly believe that that is the center of how we're gonna build the platforms to help these children. Again, with the expertise of this amazing clinical team. And so doing that together is not tech for tech, and it's like utilizing the innovation to help support this clinical model.
Great, thank you so much.
Yeah, absolutely, thank you.
Backpack health? Skip. Okay, great. Ready, set, food, Daniel? This is interesting. My daughter actually suffers from severe anaphylactic food allergies and EOE, so I'm really curious to hear about your product.
I'm so sorry to hear that.
Thank you.
So I started this business actually after my nephew developed severe food allergies also about 7.5 years ago, because there's been 23 different clinical trials now showing that you can prevent most food allergies before they start. My name is Daniel Zakowski, and as we were talking about, I have personal experience with family members with food allergies, and I think we've seen this huge opportunity in public health to really end the food allergy epidemic by preventing about 80 to 90% of food allergies before they start. But right now, about 1 in 13 babies develops a food allergy, and the problem is even worse for families on Medicaid that have about 2.5 times more severe food allergic reactions because of worse access to EpiPens and peanut-free foods, things like that. So there's a real need to make a difference across the board, but especially for families on Medicaid. But we've seen, though, with all these clinical trials, 23 of them, showing that we can prevent up to 80% of food allergies by feeding small amounts of allergenic protein to babies when they're young and doing it frequently for an extended period of time, that there is this real opportunity to make a difference and all but end the food allergy epidemic. That's why medical guidelines now say that every baby should be eating allergenic food starting when they're 4 months of age and eating those foods frequently on a regular basis for an extended period of time. And that won't prevent all food allergies, but that will end up preventing about 70 to 80% of them. The biggest challenge is that babies at 4 months of age just aren't very good at eating all those allergenic foods on a regular basis, and especially when the WIC basket of food specifically declines to add allergenic food like peanut, there's really no access in addition to it being just challenging logistically. Because you saw in the largest clinical trial, more than half of parents, even who had the tools and access and time to sign up for a clinical trial, more than half of them really struggled with implementing the food allergy protocol, and then let alone when WIC doesn't have any peanut ingredients at all, makes it all but impossible. So we've created an allergenic protein powder of peanut, egg, and milk that dissolves in whatever the baby's eating, whether it's food or breast milk or formula. That way, no matter what the baby's eating, they can have easy access to the right amount of allergenic protein to prevent food allergies based on 23 different clinical trials. So for us, we have been selling this product on the market since 2018 on Amazon, direct to consumer. We're at Target and Walmart. But I think the biggest opportunity for us is that we've launched our first Medicaid partnership in the beginning of this year with Home State Health, and we're about to launch with WellCare in Kentucky. So two great Centene plans that we're excited to build from there in the relationship, and really looking forward to bringing this product to everyone and helping everyone get access to the ability to prevent food allergies from developing. And we're excited to have that bolstered not just from the relationships we have that we're building with Home State Health and with WellCare, but Delaware actually passed legislation almost a month ago now requiring every plan in the state, both Medicaid and non-Medicaid, to start covering food allergy prevention as of January 1st, 2026. So we're just starting in this category now to have this something that's available for everyone, not just families that can afford premium priced products. But I think we're really excited this year to be really bringing this ability to implement food allergy prevention guidelines and have that ability for everyone. The last piece that I mentioned is we are now 98% enrolled on our clinical trial, which will really go towards showing that we can save money for insurance companies. Because I think aside from being the right thing to do, this will really clearly be the right thing to do for all families. Showing that we can save money by having so many fewer EpiPens and ER visits will really make this much more sustainable in the long run. So thank you very much for your time, and we're excited to partner with you to help prevent babies from getting food allergies.
Thank you so much. That's wonderful. I know we're short on time, but I want to talk to you more about that. I was really curious about the insurance side because we know the access is a huge issue. So congratulations.
Very much.
And we'll talk more. Stephen Moyo, we got you up next.
All right. Thank you for having me here today. I'm Dr. Stephen Moyo. I am CEO and founder of Welfie, and at Welfie, we're building and empowering the youth health workforce. I want to tell you about Maria. Maria is a 16-year-old girl who came into my emergency department after taking 60 pills in an attempt to end her life. Maria was sad because an immigrant like myself, after a recent move, she felt disconnected from family and friends. And she was angry, not because she tried to take her life, but because she did not take enough pills to succeed. Now, I left her room with one thought: she'd be back in the hospital, trapped in a vicious cycle of readmission where I discharge her home only for her to come right back in. And around this cycle goes until one day I discharge a patient like Maria to the morgue. This cycle is fueled by a lack of mental health care workers in our community. Today in the US, we're short over 300,000. And this is at a time where we're in the midst of a youth mental health crisis. Over 500,000 youth showed up to pediatric hospitals last year in a mental health crisis. So what is Welfie doing about it? We're building and empowering what we call the youth force. These are community health workers, peer counselors, and behavioral health coaches who are in the communities and can provide services to youth like Maria in schools, camps, and community settings. We do this by working with high schools. We build high school to healthcare pipelines and get youth trained up to become apprentices and get credentialed to become part of the youth force. That's step one. Step two is getting them hired by pediatric hospitals who are looking to have more impact on their populations, but also the FQHCs and community health centers that are critical to helping underserved families. And step three is what we're really excited about, which is building connection and optimizing this health force to actually get and work with youth, because as adults, we're not actually really good at that. So the way that we do that is we co-design with youth. We co-design all of our health education. We actually co-design our health tools with young people, young children, ages 5 and up, and also teens and adolescents. This means that with our tool and our solution, youth force members can actually send health education that youth want to watch and that they'll engage with. This builds trust. We can leverage that trust so when youth are sent an assessment, they actually tell the truth and they actually complete that assessment. And then based on that, they can use our resource library that we call the Well, which is full of over 600 resources that youth have sourced, vetted, and co-created with us. And this is what the youth force can send out, whether it's care coordination, health education, or engaging youth with healthcare providers and pediatricians. All of this is billable to Medicaid. It's health education, health assessments, it's care coordination, and it's collaborative care. And so we see a future in which Medicaid is really a fuel for preventive care in schools, camps, and community settings, and that the youth force is at the center of building that connection with youth to make sure that they're cared for. Thank you.
Great, thank you so much. That's a wonderful model. We got one more? Great, so Zócalo Health, thank you so much. That's great. Looks like they're coming. Let's swap.
Amazing. Thank you. Hi, everyone. My name is Mariza. I am co-founder at Zócalo Health. One of the things you do as a founder is name your company. I didn't realize naming a company with a Z would always put us last. So I will go quickly. I know we're out of time. At Zócalo Health, we are a community-led primary care service for the Latino community. We are focusing on treating the entire family. As you may know, in the Latino culture, multiple generations live in same households, live in same neighborhoods, and live in the same community. So we found it to be very impactful to have a care model that's led by a promotora, a community health worker, and supported by a virtual network of mental health and primary care family physicians. We have a model that is driven by community partnerships. So we are in communities, hiring our promotoras from those communities, hiring our behavioral health specialists from those communities, and building partnerships. For example, we just did all of the Head Start screenings for 5,000 preschool members in Central California. This was a great opportunity to not only meet the children and provide them information about who we are at Zócalo Health, but also to engage the families in primary care. A big part of our model is connecting families to social care and navigation services. One of our big focus areas right now in California is the CalAIM program. So we are doing enhanced care management for some of the highest risk families, with child welfare and children in the foster system being one of our biggest focus areas. So at Zócalo, we're really excited to be expanding our services across different Medicaid populations and across different states, and working with babies into our geriatric populations. So I'm super excited to be here today, and definitely thank you for the opportunity to share more about what we're doing.
Thank you so much. That's a great name. Let's give a hand for Zócalo Health and all the innovators.
I just want to say that if you want to stay and meet with some of the innovators, they each will be around. But want to thank you all for attending today. If you need anything at all, please let us know. But really, thank you for taking strides and steps into innovating for the remainder of our future, our kids. Thank you.